It's like 19 papers. And some of those papers have just very simple things to say, which it's nice. The elbow's a nice mechanical thing. There's not much to, there's not a huge amount of debate here. And so we ought to be able to bang through these quite quickly. The first thing to note is there's nothing like an Ottawa ankle rule for the elbow. The elbow, it would be nice if there was. The elbow theoretically could have such a thing. The elbow's a stable joint like the ankle is. We don't really care that much about ligamentous injuries per se, so there could be something like that, but there isn't. What we do have are the first two papers that point out that if you see someone, and this happens, you've done an AP and lateral of the elbow, the person has point tenderness somewhere around their elbow, you get an AP and lateral, they're negative. You don't, the anterior fat pad is there, but it may not be that abnormal. You don't see a posterior fat pad, you're like, I don't know. Should I do other views? What other views could I get? Well, the first thing you might do is go back to some clinical stuff. And these two papers both say that in adults, this hasn't been looked at in peds. And it's important because what's an occult elbow fracture in an adult is fundamentally different from what's an occult elbow fracture in a kid. So let's get that dispensed with. In kids, occult elbow fractures are almost always supracondylar humeral fractures type 1. Occasionally, they're epicondylar fractures in kids. So those are the two sneaky fractures in kids. In adults, the occult elbow fracture is 90+% of the time a radial head fracture. Now, the radial head, which has that little flange to it, relates closely with the capitellum. And so the capitellum is the ball, the radial head is sort of the shallow cup. When you supinate and pronate, the shallow cup has to rotate around the ball. And that requires fairly close relationship between the bony components. When you flex and extend, it goes like that. And the point is that even small deviations, small fractures, small displacements of the radial head will not allow complete range of motion. It's hard to test supination and flexion to determine, but it's easy to test full extension. And so abstracts 1 and 2 say if you've got an AP and lateral on an adult, they appear negative or you don't see anything, but that person can't extend their elbow completely. They've lost 5 or 10 degrees of extension and it hurts, that you really ought to consider doing some other views or consider calling it clinically a fracture. Number 1 by Hawksworth, 1991, said that the sensitivity of this just simple, complete elbow extension test is about 91%. That's not bad for a clinical maneuver. It's not perfect, but it's not bad. Specificity lower, as you might expect. Things that are highly sensitive are likely to be less specific, but the specificity wasn't bad either, 60-something%. The value of it worked when the age was greater than 50, so we're talking about an adult population. And they say, the way they look at this test was that if it's positive, this clinical test is positive, you need to obtain an x-ray. They don't say which x-rays. Abstract 2 looks at it the other way and says that if they can fully extend, you don't need to get an x-ray. So they emphasized in Abstract 2 the negative predictive value. I'm not sure I use elbow extension either for its positive predictive value or for its negative predictive value. What I do is if I've obtained x-rays on someone who's tender in the elbow and I don't see anything and they can't fully extend, I go to the next group of papers, which is Abstracts 3 through 6, which point out that an AP and lateral can in fact be negative on a broken radial head. In the old days, and some of you have practiced emergency medicine long enough to remember, in the old days we graded radial heads and we called them Murphy's Class 1, 2, or 3. A Murphy's Class 1 radial head fracture was where the fracture fragments were displaced less than 1 millimeter, 2 was greater than that, and 3 was obvious deformity. 4 was the radial heads completely snapped off. And the reason we used to do that was that for Murphy's Class 4 and 3, we would recommend radial head excision, so it was a surgical disease, not necessarily emergent, but they would take it out. Now we've learned that because of the close tolerance of the radial head to the capitellum, that what we should do with most of these fractures is allow the patient to mobilize their elbow and grind the fracture fragments into place. So you now have a non-displaced radial head fracture. The orthopedic treatment management strategy of choice is to place you in a sling for a couple of days with some pain meds and then mobilize you. Early mobilization to grind it into place is what they'll do. and that'll have the better outcomes. Now, in terms of documenting whether a fracture is there, I find it important. Oh, and the reason I find it important is because if you know someone's got a broken bone, and you can show them that, two things happen. One, their presentation to the emergency department is validated. We know a lot of people come to the emergency room for some validation. Whoever's around them has been telling them to stop whining, there's nothing wrong. And when you show them, you say, let me show you your fracture. They come to the x-ray. They always do the same thing. They look at the computer or the x-ray, and they always leave, oh. Like they understand it suddenly now. But it almost was always followed by an elbow of whoever's with them. See, I told you it was broke, which is an indication that they were seeking some sort of validation for their pain. And if it's broken, and you know it's broken, then they're going to be in pain. Healing, if you look at clavicle fractures, for example, in adults over the age of 40, they average 10 weeks of pain. So bones heal nicely, but they heal slowly. And so the documentation of a fracture also indicates to the patient how long they can expect to hurt. So how can we document it? Well, your AP and lateral is negative. Remember, a third of the time an anterior fat pad can be normal. We'll look at that literature in a moment. Posterior fat pads are never normal, but say there's no posterior fat pad and the anterior fat pad doesn't look impressive, but they can't fully extend. I would then do what 3 and 4 say, which is order a radial head capitellum view. It is a separate view of the elbow, which focuses, it's almost like a cone-down view that goes right between this space and shows you clearly the relationship of the radial head and the capitellum. It looks a little distorted on the x-ray because it's not a straight-through view. It kind of casts them in a long way, like in a funny house mirror, but it will really show you. And I've been amazed. AP and lateral completely looks normal to me. Patients tender over the radial head, get a radial head capitellum view, positive. And it's nice. You can show the person their fracture. You can tell them it's going to hurt for a while. And you can tell them that while the fracture, it doesn't look much displaced, you can tell them that many people with a radial head fracture are going to have one chronic pain and some loss of extension. You might think, oh, so what? They lost 4 to 5 degrees of extension. Well, think of what your patients do. If they golf, losing 5 degrees of extension, I know a lot of men for whom golf is a big thing for them. If they play tennis, I play tennis. If I was to lose 5 to 10 degrees of extension, so for some activities that extension is important. If you want to talk about how good this radial head capitellum view is, abstract 3 and 4 are very positive that say that the radial head capitellum view, you shouldn't order it all the time. You should order it on a selected basis when your first views were negative and you still think there's a fracture. It's not perfect, but it's pretty good. Abstract 5 is a little softer on it. It says, yeah, it's an okay view to get. You might get it here and there, and it might help you occasionally. They're not like, abstracts 3 and 4 love the thing, think it's great. And then just for balance, abstract 6 is included there, which is a 1990 British report that says the radial head capitellum view is not that helpful. I have personal experience getting this view with residents teaching over the last 10 years. These papers aren't new, and I've been doing it on a selected basis over that time frame. I'm pretty convinced of its utility. I don't do it all the time. I do it here and there when I really need to find out what's going on. In terms of fat pads and other things that you can find, abstracts 8 through 10 deal with fat pads, but before we get to that, we got to get to the anterior humeral line. If you have a true lateral of an elbow in a kid, humeral shaft here, capitellum there, and the forearm going there, that a line drawn down the anterior margin of the humerus should go through the middle third of the capitellum. So if you take that round ball, which is not connected by bony structures in kids, take that round ball and divide it into a middle third, an anterior third, and a posterior third. The anterior humeral line, and I have to emphasize it one more time, on a true lateral, if the tech doesn't get you a true lateral, you can be screwed up on this. But on a true lateral, that line should bisect or go through the middle third of the capitellum. What you see in occult supracondylar fractures in children, so now we're talking about occult fractures of the elbow in kids, is that that line goes through the anterior third or is tangential to the capitellum. And that's clearly abnormal, even if you don't see a fracture line. That kid has a fracture. That becomes important, and it's not 100% sensitive. In this study, abstract 7, was 68 supracondylar humeral fractures. 94% of them had an abnormal humeral line in terms of its relationship to the capitellum. So that's pretty darn good. That's a pretty reliable way of assessing kids for a type 1 supracondylar humeral fractures. Type 1 supracondylar humeral fractures, minimally displaced, can be managed as an outpatient. placed in a long arm, posterior molded splint, slinged, and sent home with orthopedist to follow Monday or whenever it is, a couple of days. Type 2s, most can be sent home. Type 3s, when the whole thing's broken off and they have a lot of swelling, most orthopedists would say to admit type 3 supracondylar humeral fractures for vascular checks so that they don't get a Volkmann's ischemia and Volkmann's contracture. So remember that severe elbow fractures in the kid, big swollen elbow, tender, a lot of pain, you're giving the kid narcotics, and then the whole thing is cracked right off at the supracondylar humeral area, those should be admitted for vascular checks. And every year there's somebody who gets convinced, oftentimes it's a junior person, but I'll see it in my office tomorrow, don't worry, put it in a splint, send it home, and they end up torched because the kid ends up with a Volkmann's contracture and a Volkmann's ischemia. It's interesting because they call it a compartment syndrome of the arm, right? Volkmann's contracture. It's not, really. There is no compartment at the elbow. It's a pseudo-compartment syndrome because there's no compartment at the elbow, true anatomic compartment. In terms of fat pads, 8, 9, and 10 say about a third of the time the anterior fat pad is normal. It depends on its shape. If this is, again, the anterior margin of the humerus, if the fat pad kind of lies in scalloped this way, that's good. That's probably a normal fat pad if you're otherwise not suspicious. If the fat pad bows out with the convexity the other way, and if it's all the way out like this in a shape like I'm drawing here, looking like the spinnaker on a sailboat, it's called a sail sign, and that's an abnormal fat pad. The posterior fat pad, if you see it, is never normal. The posterior fat and posterior joint space should hide in the olecranon recess. Shouldn't be visible on a lateral view. If you see it, it's always abnormal. And these papers remind you of these facts, but they also remind you that there are both false positives and false negatives. In other words, if the effusion isn't big enough to make the fat pad abnormal, it will be false negative looking for fat pads. And how can the fat pads be false positive? Well, you'd like to use a fat pad to identify fractures, but other fluid accumulations in the joint can cause what appears to be a fat pad as well. So villonodular synovitis, rheumatoid disease, gout, all of these things can cause a fat pad to develop. So remember, if the history of trauma is not really direct or doesn't sound like that's the issue, and it's an older person with a fat pad, you know, with rhinophyma and a fifth of whiskey in their back pocket, then it's probably gout. If it's someone with rheumatologic disorders. So a fat pad doesn't necessarily mean that it's a fracture. It can be other medical problems if there's not a good history of trauma. And then finally, in someone with a bad elbow fracture where the joint capsule is destroyed, then there's no boundary for the fat. You need to have an intact or close to intact joint capsule to create a boundary for the fat, or you won't have a fat pad. So sometimes in bad fractures of the elbow, not that you would ever miss them, you might have asked yourself, why is there no fat pad on this horrible fracture of the elbow? And there isn't one because the fat is up in the axilla. It leaked out of the bone, but it tracked up the shaft of the humerus, and literally it's in the axilla. It's gone because there was no joint capsule to create a boundary. So those papers are there for you to look at, 8, 9, and 10, that talk about fat pads. 9 it says a true statement, but it kind of has a weird conclusion in it, but it really reaches the same conclusions. Most fat pads, it says, are false positives at this University of Cincinnati paper, but that it fails to acknowledge that you might understand the difference in shape between a normal anterior fat pad and an abnormal anterior fat pad. In other words, they just said fat pad present or negative. So it kind of reaches a wrong conclusion. Nursemaid's elbows, nothing I like more than a nursemaid's elbow. Mom comes in, thinks there's something dreadfully wrong, my child won't move. Sometimes the history's hard to find. They were on a playground and it got jerked, or the kid was throwing a tantrum on the floor of Kmart and mom said, get up and come with me, that kind of thing. But it's a sharp pull on that extends an arm in a kid with a poorly developed radial head and a weak annular ligament. That's what causes a nursemaid's elbow. The radial head, which is not that large, jumps the annular ligament, and they're easy to relocate. The standard in-service or board review question is to say that you should, and I can't leave the box. Can't leave the box. I was going to use your elbow. You see how lucky you are? You've been spared it. Is to supinate and flex. But supination and flexion, what happens is you really need to put your thumb pressure over the radial head when you do that, and then you'll feel it click right up. And when I see our pediatricians sending kids up, it's not a nursemaid's, it wouldn't reduce. all I do is put my thumb a little bit below it and a little pressure, it reduces right away. If supination and flexion doesn't reduce it, you should immediately take it into full extension and then put it into full pronation. And it will go. Almost all the time it will go promptly if you know how to do both of those maneuvers simultaneously. So it's supination and flexion, failure, full extension and pronation, for both maneuvers with gentle pressure over the radial head with your thumb upward to help the radial head jump the annular ligament back into place. I love these because the parents are happy, the kid's moving. How long should you wait for the kid to move? These papers deal with this. A couple of them talk about it if you get the original manuscripts. It's been specifically asked. The kid should, you know, the nurses are always dangling some puppet, some treat, trying to get the kid to reach. And if the kid won't reach or move the arm in 30 minutes, think again. Start x-raying, because it's probably a supracondylar humeral fracture. About 95% of kids with a nursemaid's elbow will move by 30 minutes if it's reduced. Either you didn't reduce it, or it's a supracondylar humeral if they're not moving at 30 minutes. And then 12 is a funny paper. 12, you know, pediatricians, how many pediatricians in here? Okay, so I can speak truth. So the pediatrician's job is well child care and longitudinal care vaccines, and obviously that's very important. There's no bigger bang for your buck than vaccinating children, so that's real important. But the rest of the time, they're prescribing antibiotics that don't need prescribed over the phone. They do an alarming amount of phone. Yeah, here's some amoxicillin. It's amazing how much they write for prescriptions over the phone. This paper says, yeah, and nursemaids, handle that over the phone too. Abstract 12 says, this is so easy to relocate, just tell the mom what to do and she'll put it back in. I'm like, why would you do that? This is why I went into emergency medicine, is to do these relocations. I love it. Next question is on olecranon bursitis. Depending on how charitable or how critical you are, the person comes in with a golf ball over their elbow, like this, and it's either drunkard's elbow or student's elbow, right? You know, from repetitive micro trauma and bearing weight on their elbow is what causes it. We see a lot of this in the homeless. About 80% of them, or thereabouts, are traumatic, and the remainder are infectious, with about 1% gouty. Less than 1% probably. So, what do you need to do? If you look in any textbook, they'll tell you you should stick a needle in it, get the fluid out, and send it for about $750 worth of tests. Those tests would include checking how sticky the snot is, the mucin strand test. You know, the more infected it is, the less stringy and snotty it is. They would include a cell count, a culture, a gram stain, and a sensitivity, and crystals. Now, this is nuts because, again, you'll have to humor me with my great visual aids. This circle, picture it right here. This circle right here is the lab results of the non-infected, that includes all of the non-infected traumatic bursitis. This circle, I moved over a little bit, right here, this circle right here is the results from the infected one. Statistically, this circle is different from this circle. The problem is that the overlap zone in the middle is 90% of the contents of both circles. And so the ability of lab tests to differentiate the septic one from the non-septic one is low. Why would you spend $750 of tests for a test that doesn't tell you the answer, even when you do all of them? And finally, if it's infected, does olecranon bursitis, other things being equal, the person's healthy, well, you know, has ways to take meds, etc., no comorbidities, do they come in? No, it's an extra-articular process. So if they're infected, it's not even, you're not even at the branch point, admission or home. They're still going to go home. So why would you do that? What I think should be done rashly, and many other experts in this agree, say you should aspirate the fluid. Try not to IND these. When you IND them, they keep splitting open, and that's true over the knee for the suprapatellar ones as it is over the elbow. So use an 18 gauge or the biggest needle you can and aspirate all the fluid, collapse the sac, and then look at both the skin and the fluid that comes out. If the fluid is gross pus, if you're curious, go ahead and just put a urine dipstick in it. If it's positive for leukocyte x-rays, it's pus. If it's grossly pus, or if the overlying skin looks infected, then this is an infected one and you should treat it. You're going to treat him as an outpatient, and you should do. If the fluid looks straw and the skin overlying is quiet, you should call it non-infected, and you need to do no tests. You need to aspirate it and then put a compressive dressing on it. And that's basically what abstracts 13 through 15 offer up. They say that this is largely a clinical thing. The one place where there's a role for a test which would change your management is if you wanted to ask for crystals. Now, gout, as you know, prefers to be intra-articular. 90% of all gout is an intra-articular process. But there are still, that means, another 10% where gout is extra-articular. And the places that gout likes to be extra-articular are few in number and largely in the lower extremity. So it likes the anserine bursa, kind of medial to the knee and distal, and it likes the ankle and the dorsum of the foot for extra-articular around the ankle. And you'll know that. You probably have called it cellulitis. I certainly did before I knew much about this and admitted it. Anytime you see a dorsum of the foot cellulitis that hasn't gone up the leg, right? Most cellulitises are the leg, not the foot. If you see a dorsal foot cellulitis that even you just touch it lightly, the patient screams, that's probably extra-articular gout in the extensor tendons and at the extensor retinaculum of the foot. That's what that is. And that's why it doesn't get better with Ancef, it gets better with Indocin. Having noted that, occasionally extra-articular gout will give you an olecranon bursitis. And so the one test that you could do is ask for crystal analysis. Because if it's gout, then that changes what you're doing. But the rest of it is all clinical decision-making. Abstract 13 from OHSU says there's 3 types, 80% traumatic, 20% septic, and occasionally crystal-induced. Abstract 14 says get a surface temperature probe to tell if it's infected. No. I have a surface temperature probe. It's called the back of my hand. If it's hot, feels hot, and looks red, I don't really need a surface temperature probe, thank you very much. They say the sensitivity just looking for the surface temperature variations was 78%. Not that great. I think that this is largely, which side would you err on, infected or uninfected? Infected. If we said that 20% of them were infected and you wrote antibiotics for 30% of them, covering all the infected ones plus a couple marginal ones, who cares? It's an outpatient thing. That's fine. That's appropriate. That's the way to do this, is to treat them as traumatic most of the time when it's pretty clear that that's what it is. The skin is quiet, the fluid's straw colored, there's no evidence of an infection. And anytime there's some redness or they look bad or it looks a little murky, go ahead and call them infected. Abstract 15 is again from OHSU and says aspirate, don't IND. Emphasizes that point. Says that when you put a compressive dressing and an elbow pad on them so they don't recur their microtrauma, this is one of the few papers that will tell you how long should that be done for. So yeah, they say really they need 10 days of padding at least on their elbow because otherwise they recur. And the main cause of recurrence is inadequate aspiration and 2, inadequate length and amount of protection for the elbow from the microtrauma. The microtrauma that these people have, you can tell them don't lean on your elbow. They aren't even consciously aware of their habitual bearing their weight on their elbows. So you actually have to put a pad on their elbow. They have to have an elbow pad because they'll continually redo it. Tennis elbow, lateral epicondylitis. We got 3 papers that deal with this topic, 16, 17, and 18. 2000, and what should you do about that? Well, what are the things you could do? You could put that band, you know all the tennis players wear that band there? Does that work, the little orthotic thing, the band? No. It does what every other band or splint does in sports. It reminds you, you know those big knee braces? The literature on them, do they work? Almost none of them work. What the big knee brace does is remind the athlete, you got a fucked up knee, be careful. And the same thing, this is the same thing this brace does, is it reminds you, you got a hurt elbow, you know, be easy with it. What this literature says is there's a bunch of things you can do. You can do steroids, you could do orthotics, you could do acupuncture, you could do, you know, ultrasound, you could do all kinds of things. But the thing that seems to work best, brace yourself for this breaking news. Avoidance of the activity that caused the problem. So if you're a little league pitcher, stop pitching. If you're a tennis player, stop playing tennis. If you're a golfer, stop playing golf for long enough for it to get better. NSAIDs help a little bit. What the meta-analysis, there's 117, it's a Cochrane meta-analysis says, 16 is the Cochrane review, which says that steroids, which you might use, you should be careful with. And the reason is because steroids work. So what happens when the person with the sore elbow takes the steroids and it works? They call their buddy, hey, you want to go play some tennis? My elbow's feeling great. And so they reintroduce the activity earlier with steroids. That's not necessarily a reason to avoid steroids, but if you are going to use them, you need to really tell them, don't reintroduce the activity or you're going to get into trouble with this again. That an adequate period of rest and NSAIDs is the way to go. 18 says that physical therapy does work in the long term, steroids does work in the short term, but that watchful waiting and avoidance of activity performed almost as well in 185 adults with this problem. So this is one of those places where, doing the common sense things work. Now 17, I do have to bring you on one thing. They added another question. They looked at NSAIDs for 2 weeks, and they also looked at some placebo stuff and said that the placebo worked almost as well as NSAIDs. So be easy with the NSAIDs, because if you put on someone on for NSAIDs for 2 weeks, you just heard the talk on ketorolac. I mean, NSAIDs are Black & Decker stomach wreckers, and the key thing on whether or not they wreck your stomach is how long you're on them. And so 2 weeks would be a long time for someone to be on 400 or 600 of Motrin 3 times a day. In the 15 years that I ran the residency at LA County, I had 2 residents present with perfs. What happens is this. They think that they're taking Motrin or whatever NSAID they've chosen, that they'll know that they're going to have a problem because they'll have some stomach upset or some blah, 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 before it happens. And absolutely, it's well established that there is often no warning symptoms until you're perfed. So if you think you'll know that the NSAID is eating a hole in your stomach, you're wrong. You won't. You won't. So you really need to focus on short course. And then the last thing that I want to talk about, although there's not a paper on here, just because I've seen a bunch of cases recently, is elbow dislocations. The vast majority of elbow dislocations are posterior dislocations. They usually have a medial or a lateral component to them. And the only thing I just want to say before we end for the day is this, that at any time, most times when you do a joint relocation, what do you think the circulation is going to be when you're done? Better or worse? Better. Most people have tenuous pulses while the thing is out, and they improve dramatically when you put it in because all the tension and things are taken off. The one exception to that rule is the elbow dislocation. Occasionally, and if you just do a casual PubMed search, you'll find case after case after case where someone relocated an elbow, thought everything looked good, and it was in, and they did a quick, the arm didn't look ischemic, and they may or may not have checked pulses, but they didn't do it very carefully, and they let the person go, and they ended up amped or with a graft and a surgical thing needing to be done. It is the one relocation where entrapment of the brachial artery happens as part of the procedure. So post-procedural pulse checks a lot of times are sort of show and go. It's something you need to do to get your conscious sedation. You remember in conscious sedation to get the billing right, you got to document the vital signs and a vascular check afterwards. So we all chart that to get paid for our conscious sedation. But this is the one area in the elbow where you really better check them, because it's the one relocation that actually catches vascular structures with some frequency. So if you relocate an elbow, please check the pulses afterward. And I'll stop there, and I'm going to go for a good lunch. Go ahead, questions? Absolutely. So I didn't touch on this, but so MRSA, clearly about 70% of isolates at LA County right now are MRSA. Our MRSA is progressive. By that I mean we're up to 90% Clinda resistance. So Clinda's dead at LA County. We do Bactrim and rifampin. There's no question that if you're seeing a lot of MRSA and you see what looks like an infected olecranon bursitis, that you should cover MRSA. Now, Greg Moran and Dave Talon, if you were to talk to them, they would say that MRSA doesn't usually produce a big cellulitis. It produces focal infections, furuncles, abscesses, and other things, that little eschar thing that you see. And that if you see a larger cellulitis with an olecranon bursitis, once you start getting to big territories of cellulitis around it, that you ought to worry more about strep. And maybe you ought to put them on Keflex and Bactrim to augment your strep coverage. But yes, there's no question that MRSA is associated with the infected olecranon bursa. In our homeless community that we're seeing at County Hospital, some of them are failing outpatient management with stuff, and we have to bring them back, and sometimes they even have to be hospitalized. Usually it's a combination of treatment failure plus comorbidities that results in their hospitalization. Most olecranon bursitises can go home. Every once in a while you'll see a truly septic olecranon bursitis where the patient looks like crap And they should come in, but it's usually a comorbidity issue. Yeah. Is it the MRSA question or general? All right, so in general, I think a week is fine. If you're talking about MRSA and you're having peskier problems with that, we're usually going up to 10 days. Do I have any basis for that statement for duration of therapy? The answer is no. We're in the realm of pure opinion now. The longer length of treatment for MRSA is based on what we're seeing as some treatment failures. And so we're thinking, well, maybe hit it for longer. Bactrim does cover strep, and I love your question, but they say that the coverage in skin is not so good. And so they recommend Bactrim and Keflex. And so, you know, for a pneumonia that's strep, the Bactrim should cover it, but it doesn't cover skin and soft tissue infections particularly well. And so that's why you augment up. For just plain MRSA concerns, we're using both Bactrim and rifampin. Usually the rifampin for 4 or 5 days and the Bactrim for 10. The purposes of there's a lot there, by the way, with the MRSA questions, and I'm not really here to talk just about that, there's more things unanswered than answered. Duration of therapy, the need for combination rifampin, the role of surgical care, the need for debridement, the issue of whether or not cleaning your nose and things like that will decrease carriage. We know that Bactrim doesn't eliminate vestibulitis and vestibular carriage. The rifampin does. And just the last thing I'll tell you, it's referred to at times at our hospital as the Mallon maneuver. You know, you have those little alcohol things, you know, to clean your hands, the antibiotic, bacteriostatic ones. Here's the move. Into the hands, get a lot of it. Do the hands before it's all dried up off your hands. Get the nose, so you're not getting if you see any healthcare worker with some crusting and dry stuff here, they're all colonized with MRSA in their noses. Get your nose, and the last move, unless you're fashionable and thin, all of our young residents want to wear their stethoscopes in their holster on their hip. You know, they got the holster for their stethoscopes. But if you're like an old timer like me, you wear your stethoscope on your neck. And I have already IND'd about a dozen healthcare workers with a nasty MRSA furunculosis on the back of their neck. And the reason they got that is because their stethoscope is rubbing the MRSA into their hair follicles on the back of their neck. And so the last move is it's nose, back of the head where the stethoscope goes, so that you don't get your MRSA there. Keep those areas off.